Namaskar, a very good evening, my dear friends, colleagues. Greetings from India. I'm Mukesh Jain, faculty in radiation technology at SMS Medical College. Since 23 years, I'm in teaching and administration at SMS Medical College. I am presently performing my research work on Monte Carlo simulations in radiation doses, diagnostic radiology and radiation technology. So today I welcome you all to the 23rd Asia CPD program hosted by Indian Society of Radiographers and Technologists. In India, we have just celebrated the Festival of Colors to spread the colors of life and joy. And today, ISRT, in association with its intracontinental allies, is going to spread the different colors of radiation technology. We have 3 lectures from our eminent speakers on 3 different topics. So before we start, being an ISRTian, I request our guests and companions to be with us, encouraging and motivating us to keep the continuing professional development of the fraternity. Now, I would like to invite our inspirational and visionary leader, our president, sir, Mr. A. Selva Kumar, sir, to share
Namaste.
a few words and blessings with us.
Namaste, Swagatam. Very good evening. Greetings from India. Warm welcome to dear all. It's our pleasure and honored moment for ISRT, Indian Society of Radiographers and Technologists, to be a part of ISRT CPD program, Asia CPD program, and our gratitude and sincere thanks to all member countries and respected presidents in approving the same. This 23rd Asia CPD event we are hosting today has approved, and thanking you all beloved members, including Asia CPD General Secretary Ms. Pichi Luna and the team. I extending warm welcome to Mr. Suresh Malayat, our Dynamic General Secretary of ISRT, and Ms. Pichi Luna, and our respected presidents of respective Asian countries, Radiographers Association, and other representatives, requesting all to be a part of this program and be a panelist to this webinar and guide us and improving these sessions. Once again, welcome you all to this 23rd Asia CPD program. ISRT is a national apex body in India, taking care of all of our radiographers. And we are regularly updating our members and Indian radiographers with continuing medical education programs and regional conferences to update national-wide and be a part of this ISRT also. And we have our 2 subsidiaries programs. One is our monthly magazine called Alara. Through this, we are our radiographers are throughout India and other person, those working in outside also, presenting, giving papers in that and throughout updated things. And we are very collaborated with our Indian government, with the Ministry of Health also, to make the basic programs and updating our radiographer societies and field. I would like to highlight the recent COVID pandemic time. The world it is like a curse to the mankind. But we professional to felt the evil effects of the same, and our few fellow colleagues too lost their life during the patient services. In spite of that, as a technical member of this medical group, we feel it as a gift. It gave us in the form of uniting the member countries together from far off places throughout the Asian region and all the continents of world, and starting the webinars, enhancing our skill by mutual sharing the knowledge, understanding various modern techniques, practices to improve the quality patient's care, and to upgrade ourselves with reorientation, updated knowledge, at comfort of sitting home without going anywhere. In today's CPD program, we have three valuable presentations and two on the CT images, and one is evaluation of factors affecting enhancement of contrast during CT examination. And our speakers are a very renowned person. They are the in charges of their respective departments from the universities. And the month of March, we are celebrating as a Women's Day. So in our today's program, you can see two of our participants from the female, and the topics also covered with female imaging services. The warm welcome you all to this event, and once again thanking you all to making this occasion a memorable one. Without wasting your precious time, I will hand over this to the moderator. Thank you all. Welcome. Namaste.
Thank you, sir, for kind words. It's very inspirational for us to be in the field. Now, I would like to invite our innovative, dedicated Mr. Suresh Maliat, who is tirelessly working for the fraternity. He is one of the most fabulous healthcare leader or General Secretary, Suresh Maliat, to say a few words.
Namaste. Good evening, all. I think I am audible to all. Am I audible, Mr. Mukesh Jain?
Yes, sir.
Okay. Warm greetings from India. I think Mr. Selva Kumar has briefed ISRT and the intention and the long track record of ISRT in academic and professional updates. I'm grateful. It is with a deeper sense of joy, hope, and gratitude that I'm addressing you all, the Asian societies, especially Pichi, Luna, and all others. I'm grateful to the leaders for selecting India to host one of the programs in this series. As Mr. Shilakumar told, it is the curse of COVID has become an opportunity for the technology people in radiology, in healthcare, and as well as other scientific innovations. Especially in radiology, we have switched over to the the online or virtual events throughout the COVID days, and this is a sustainable program. And thus, the CPD, we have to change the CPD as sustainable CPD is a professional development program, not a continuous professional development program. It is a sustainable professional development program, and any person across the globe can join any event initiated by these technology people. I wish to give a big salute to Pichi, Luna, and all Asian societies for initiating a unique program like this. As Selva Kumar told, this is a time of women empowerment, and we have a young group, a young generation, emerging young generation across the India in this field. And as everyone knows, India is a vast country, and this is one of the biggest countries in the world, and that is the fifth largest economy and second largest country in terms of population. For radiographers, also we have a good young and dynamic people, and we are looking forward for more and more activities in future. And I have a request to our organizers. We have to coordinate all Asian countries, including the Middle East, Palestine, UAE, and Sri Lanka, some other countries also. There's those who are not joined with us. And this Asian CPD, we have to develop the Asia-Australia CPD programs as we are conducting the regional conference. I wish a very good and informative session ahead. Thank you. Thank you all.
Thank you, sir, for your kind words, inspiration about the requirement of these kind of CPD programs. And definitely, the woman empowerment is a prime motive. And now we are working in the era of just celebrated the Women's Day. And we belong to a country that where the woman is worshipped. So before going ahead, I would like to invite our best innovative researcher, accreditor, and the fraternity ambassador, Secretary General of the Philippine Association of Radiologic Technologists, PAT, and the Philippine Association of Deans and Faculty of Colleges, of Radiation Technology and the International Council member of ISRT, Mrs. Pichiluna ma'am, to share few words with our audience and with us.
Yes, thank you, Mukesh. Hi, everyone from India, Asia, and all over the world. I am delighted to briefly introduce to you CPD Asia, the online continuing professional development platform for Asian radiological technologists societies. This is founded in November of year 2020, and then from 5 founding associations, we grew each year, and now we are composed of 12 active societies from Asia, and one of the new societies that have formally joined is ISRT. And one of the main objectives of CPD Asia is to strengthen our cooperation and exchange between radiological technologist associations from Asian countries and regions. And of course, basically to promote CPD or continuing professional development and improve professional level of medical radiation technology in Asian countries and regions that have joined to share our academic training resources, evidence-based practices for professional development of radiographers and radiological technologists. So like all of you, I am also equally excited to see what is prepared for us by the ISRT's program. Thank you, Mukesh.
Thank you, ma'am, for the inspirational words and the requirement of the CPD. And we are also very happy to be a part of that 12 countries and hoping we'll see more and more in future. Now, after the insightful blessings from you, now I'd like to invite our president of 12 Asian countries to share few words with us. Mr. Geek Sugianto from Indonesia, President. Is he here? Okay.
Please, silakan Bapak Ketum.
Fernando Cox, sir, from Macau, President.
Yes, hello. Congratulations. India is the first time to join us. Welcome all, and thanks to support. And I hope we can years and years continue this Asia CPD platform. Thank you.
Thank you, sir.
Thai Van Lock, sir, from Vietnam, President. From Vietnam.
Yeah, thank you. Thank you, Zen. Good evening, everyone.
Yeah.
Also, congratulations, ISRT. Welcome on ICCPD, Asia CPD. Congratulations. Thank you so much.
Sir.
Thank you, ISRT.
Thank you so much.
Thank you.
Okay.
Mukesh Sugianta, sir, is there?
Yeah, sir. I'll Geek Sugianta, sir, from Indonesia.
Hello, good evening,
Good evening, sir.
all of friends, presidents, yeah, Mr. Silva, yeah.
Yes, sir. Thank you.
Yeah, Inen Tan from panelist from Myanmar. Yen Navayo, Myanmar from panelist.
Hello, good evening, everyone. Nice to meet you again. Congratulations, India. See you later.
Yeah, Sophia Lehman from Cambodia. Okay, Nelson Vaughan from Hong Kong. Might be. Chen Yon Tu from Taiwan. Okay, Denai Chong from Singapore.
Good evening, everyone. I'm Denise from Singapore, and congratulations to the ISRT for joining us at the Asia CPD. I look forward to this evening's program and for future collaboration with you as part of our Asia CPD team.
Thank you, ma'am. Thank you.
Thank you.
Joyce Tan from Singapore. Shokai from Singapore. Tumsi Bukarech from Mongolia. Sawal Mashik from Malaysia. Mohammad Al-Ghani sir from Palestine. Hashim Al-Avdi sir from UAE. Pichiluna ma'am from Philippines again.
Yes, good evening again.
Okay, and then one of our most Selva sir. Okay, so thank you all for good wishes, and we'll keep with us for a long. And now I'd like to move towards our professional lecture section. Before that,
Good evening, Mukesh. One break. With all the panelists, we can have one group photo.
Yeah, sure, sir. So may I request
I'll ask all the panelists to open their cameras.
Yeah,
we can have one.
So may I request all the panelists and the intercontinental allies to switch on their cameras so we can have a group photo. After that, we'll move towards the lecture session. In that, we'll having 3 lectures from our eminent speaker. And so may I request to turn on their cameras. Okay. Sure,
Recording in progress. Recording stopped.
Thank you. We'll continue the program.
Yes, sir. Maestro, will you please continue? Yeah. Yeah, after the blessings, we'll have our lecture session from our eminent speaker. So, are the speakers all here? Thank you, sir, for inspirational words. It's valuable for us. Now, I would like to move towards our professional lecture session. Before the session commences, I would like to request all the audience to kindly post their queries and suggestions in the chat box. They will be addressed by the speakers or the panelists at the end of this session. So stay tuned with us. Firstly, I would like to invite our eminent speaker, Mr. Shashikumar Shetty. Mr. Shetty has an experience of over 16 years. He is presently working as assistant professor and head of medical imaging technology at KSH Medical College, Karnataka. Mr. Shetty has MSc in medical imaging technology from Manipal University and presently pursuing PhD from NITE University. He is working on 2 research projects on biodosimetry and having 5 publications in national and international journals. He is also governing body member of Indian College of Radiation Technology and presently a regional coordinator for ISRT. So today he is going to speak about the evaluation factors affecting enhancement of contrast CT examinations, consideration and approaches. So the virtual floor is open for you, sir.
Hi everyone, myself Shashkumar Shetty. I'm the ISRT Regional Coordinator of the Southwest India. I'm also working as an assistant professor and program coordinator of medical imaging technology, KS Hegde Medical Academy, NITE, deemed to be University. It is an honor and privilege to be part of 23rd Asia CPD program for Asian Radiologic Technologist Societies, which is hosted by Indian Society of Radiographers and Technologists. My dear radiologic technologists and students, today I'm going to present evaluation of factors affecting enhancement of contrast during CT examination, that is consideration and approaches. All of you know about, since the introduction of the CT in 1974, a lot of development had taken place. After especially introduction of the MDCT, there are a lot of technical advances. Everyone know about that there are two types of scan. One is non-contrast scan, which is also called plain study. The another one is contrast scan, where we inject non-ionic iodinated contrast into the blood vessel to see the structure of the vascular system and as well as the internal structure of the body. I will start with my presentation giving one example. Usually what we will do when we are injecting contrast to patient, we will place the cannula at the level of wrist or antecubital vein. So now here I'm giving an example. If it is cannula is placed at the level of wrist, what will happen? We'll inject the contrast, right? So before that, we will place the locator and tracker to exactly locate the place, then place the ROI and track the contrast reaching at that particular area. You know that, all of you, that the reaching that contrast at particular area, it will vary patient to patient. It is not exactly same for all the patient. See, here is the research proof that contrast was injected to the patient with a threshold value of 150 HU at the level of abdominal aorta. The mean aortic enhancement time means AET for the male around it was 19.55 seconds. For the female, it was around 17.64 seconds. It means there is a changes in time contrast reaching to particular area. As I said earlier, the contrast enhancement at CT is affected by three main factors. One is patient factors, the second one is CT scanning factors, and the third one is contrast medium factors. If you take a consideration of the patient factors, there might be depends on target organs. I already shown the difference at the chest and the abdomen level. Maybe other magnitude kind weight, height, cardiac output, age, and the gender is one of the main important factors affecting. Maybe cardiac output and venous access, I will explain it later. Breath holding, renal function, peripheral vascular disease, and will also be a part of the factors affecting. If you take a consideration of CT scanning factors, scan duration and scan delay, in a third one, contrast factors, kind of concentration, the rate of injection, and the saline flush. These are the three different factors which is going to affect in the contrast enhancement. I will explain it in briefly with the relevant research article. Once completion of the plain study or non-contrast imaging, we are going to inject the contrast by method of smart prep or bolus tracking. Each equipment vendor has a different name for this option. Example, if we are doing abdomen scan, we are keeping the locator at the level of D11, D12, and for that we take one single image. Later, we will place the ROI to track the flow of contrast during the injection. Look at the scan bar. We are starting contrast injection, and at the same time, axial mode images also taken to track the contrast. You can see in the graph after reaching the contrast, we started taking image. Fourth image is going on now. Fifth image, same time. The increase in Hounsfield unit graph also it is showing. Once the 80 HU crosses of the threshold, automatically scan will take place and the arterial phase scan will start. As I said earlier, there are three different factors as affected by the contrast enhancement. This is already I explained in the previous slide. Now I will explain three different factors one by one. First, I will explain how patient weight factors will affect the contrast enhancement. For example, the adult male, 30 years old, height about 170 centimeter, and 125 ml of contrast medium is injected at the rate of 4 ml per second. Here, there are 4 different body weight of the patient: 50 kg, 75 kg, 100 and 125 kg. Is a given example here. What it will show, the magnitude of aortic enhancement are inversely proportional to the body weight. See here example, 50 kg body weight of the patient is nearly about 350 to 400 between the Hounsfield unit. If the patient weight is around 125 kg, you can see that the enhancement around between the 200 and 250 Hounsfield unit. But other parameters, as I said, all were constant other than the patient body weight. And similarly, cardiac output also, which is one of the important factors, is directly proportional to the contrast bolus arrival time, known as the time to peak, or some of the article
recording in progress.
Aortic enhancement time also is mentioned, which is cardiac output decreases, the circulation time increases. This leads to delay in TTP and increased vascular contrast opacification due to the slower clearance of the contrast medium volume. See, here's the example of the cardiac output, how it will affect the enhancement. Again here, the patient factors are constant. Example, adult male, 30 years old, weight about 70 kilo, height about 170 centimeter, and 125 ml of contrast media injected with the 350 mg of iodine per milliliter at 4 ml second. But there are 3 different cardiac output reduction are used. See here example, as the reduced cardiac output, example here is 60% of the reduction, where contrast material bolus arrives slowly and clears also slowly, reducing in a delayed contrast material bolus arrival, as well as delayed as well as elevated peak arterial phase. You can see the difference between the baseline of the contrast enhancement as well as the 60% reduction in the cardiac output enhancement also you can make out. The vascular site, in the sense the placing is injecting the contrast, also one of the factors affecting in contrast enhancement. Example here, we have placed the cannula at the level of wrist and we are injecting contrast to the patient during the scan of thoracic CT, and we have placed a locator and tracker at the level of carina. So you can see that reaching contrast from the wrist compared to the cannula is placed at the level of antecubital vein is a shorter distance, so that the distance when it is short to the heart, the lesser the dilution of the contrast. So there's always use the cannula at the level of antecubital vein, and also is always better to have right side selection compared to the left side selection, because the distance closer to the heart than the left side. The injection duration also defined as a total contrast volume divided by the injection rate. Has affected the TTP and extended of vascular enhancement. The longer injection periods delay the maximum delayed TTP. See, here is the example of contrast volume, how the contrast enhance will affect. Here patient demographic data is constant, subjected to 3 different volumes, where used 75 ml, 125 ml and 175 ml contrast are injected to the patient. You can see here the magnitude of the peak of the enhancement increases with the contrast medium volume, but the larger volume requires longer duration to inject. You can see here, if it is 175 ml contrast we are injecting to the patient, it is required around, to complete the total volume, it required around 100 seconds. But if you are injecting it at 75 ml, there is around 45 seconds. The duration is longer if you are using the larger amount of the contrast. But same time, we will have the higher enhancement also if we increase the amount of the contrast. Injection rate, we're keeping volume and the iodine concentration of the contrast media constant. An increase in the injection rate will increase the extent of vascular opacification. But the faster injection rate provides greater vascular opacification and reduces the temporal windows during CT. See here again, the flow rate, how it will affect the contrast enhancement. Here again, the demographic data of the patient is constant, where the flow rate we have kept here at 3 different, I'm showing here 3 different ml of contrast is injected per second. As the rate of injection increases, here is giving example of 5 ml per second, the magnitude of the contrast enhancement also increases, but the duration of the contrast, the high magnitude contrast enhancement also will decreases. That has to be kept in mind when we are injecting contrast at the rate of different flow rates. So always using saline chaser is where decrease the amount of required contrast media volume without affecting the level of vascular opacification. There are a lot of articles are there, research article published, where saline chaser was found to increase the extent of peak arterial opacification. A few study also suggested that faster saline chaser rates may not result a further increase in the degree of contrast opacification. So whenever we are using this saline chaser, we should consider this points. Same time, contrast concentration, keeping the injection rate, volume and injection duration of contrast media constant, vessel opacification increases, but TTP, the enhancement, peak enhancement is unaffected since the duration and rate in injection remains fixed. It's also given injecting a small volume of high concentration contrast media at fixed rate leads to early peak but a shorter duration of a contrast enhancement. Here is the example of concentration of the contrast versus enhancement. The patient demographic data is constant, where we used adult male 30 years old patient, weight about 70 kilo and height about 170 centimeter. 125 ml of contrast is injected for all the 3 patients, but with the 3 different varying concentration, we injected at the flow rate of 4 ml per second. Concentrate as it is increases. You can see here the medium of with a higher concentration delivers a larger dose of iodine faster and result higher magnitude of peak contrast enhancement. You can see that if it is 350 mg of iodine per liter, if it is given, you can see the enhancement around about 300 Hounsfield unit, where 400 iodine per 400 mg of iodine per milliliter, if it is injected at the flow rate of 4 ml per second, the Hounsfield unit around about 350. As the higher magnitude of contrast peak enhancement, the same time wider temporal window for CT imaging also will be given. That's the better benefit. But where if you're using the concentration is lesser compared to the 400 mg, then there will be a temporal window will be lesser. Scan duration, one of the important factor. Long scan duration, it's a necessity to long injection time and vice versa. The mechanical delay can be, it can't be excluded. It is one of the technical issue, but there are few methods. Also, you can use the minimum scan delay and scan direction. That's also one of the important factors during a scan duration. During scan. See here, I'll give you one graph of contrast media injection, enhancement and scan time variables, which is demonstrating a scan delay and additional diagnostic delay. You can see here the bolus tracking threshold. Example, we have kept bolus tracking threshold around 50 Hounsfield unit. You can see that after crossing the threshold, the additional diagnostic delay will be there before scanning, before taking place of scanning. It is called additional diagnostic delay. Between this trigger time and the additional trigger time and the scan duration, it is called additional diagnostic delay, where most of the time we'll have, I've seen that many equipment at least will have 3 seconds of minimum 3 seconds of diagnostic or additional delay will be there. Now, sometimes you can reduce that. Example, I'm giving here one example. Now we are taking abdomen scan. This is the below red color with the faded block, which is showing scanning area, and this is the red line which is showing the locator, which is kept at the level of thoracic. Now, locator to distance between the starting scan region. If you minimize this distance, you can reduce the diagnostic delay. There are very few articles published in this. If it is anyone interested, definitely you can take up research work in this. You can have the different locator and the scanning starting location, so that you can see the variations of the additional diagnostic delay in the different patient during the scan, maybe in thorax, maybe in the abdomen. So here another graph image which is giving time enhancement curve and scan delay diagram for organs at different circulatory paths. You can see if it is pulmonary artery, you can see that the enhancement and the time graph. You can see the scan delay and the duration, which is very useful because whenever injecting contrast, most of the places still pressure injector are not used. So that time this graph will help you, and it will help you to calculate the time exactly. Might predict, you can predict that the contrast will reach in this particular time while starting pulmonary angio, maybe aortic angio or any peripheral angio. When you conduct, it will help this. You can always refer this for doing this, conducting this. So other factors, tube voltage, which is decreasing CT tube voltage leading to increased vascular opacification. As an X-ray photon energy gets closer to the KH of iodine at lower voltage. Low voltage increase the vascular opacity, and it also reduces the volume and concentration of contrast medium needed. It's very important. And also reduces the radiation dose if it is tube voltage. There are a lot of radiation reducing techniques are there anyway. But the disadvantages is more noise, increases contrast media, increases the radiation dose. You can see there are many published articles available. Here I'm showing the graph representation to show the relationship between iodine concentration and CT enhancement at 3 different voltage settings. Here, for a given voltage, the proportionality of contrast enhancement to iodine concentration is near constant, and a increase in a concentration by 1 mg of iodine per milliliter, the contrast enhancement of, you can see that with the 80 kVp, the HU value will be around the 41, where with the 120 kVp, the HU value will be nearly around 26. Means use of lower voltage results in a stronger contrast enhancement per iodine concentration. Till now, you have gone through the many graphs, research work on different factors affecting contrast media during a CT scan. I'm going to conclude here, which is this study can help designing better protocols, taking into consideration the variations of the mentioned factors in each individual patient. It also helps to optimize the injection protocol for patients of different age and gender. Find the accurate scan phase timing is very important. I given few of the example. Helps contrast enhancement in a fixed scan delay. This contrast medium injection rate based on patient specific formula further reduces the amount of radiation dose. If you are keeping consideration all 3 different factors which I explained, you can have better imaging, better opacification of the blood vessels or particular area or any organ, and also you can reduce the radiation dose to the patient. Here I'm showing few reputed research articles published in a reputed journal for further reading purpose. These are the articles well explained about factors affecting during the contrast enhancement, which I was explained in a previous slide. Please go through that and increase your knowledge. With this, I thank our Indian Society of Radiographers and Technologists for hosting this 23rd Asia CPD program for Asian Radiological Technologists and Societies. First at most, I thank Suresh Malyat, sir, who is the General Secretary of ISRT, and Mr. Selva Kumar, President of ISRT, for giving me the opportunity. And also, I thank for gracing the occasion Ms. Picha Luna, the Secretary General CPD Asia, for gracing this occasion. I wish luck for remaining speaker of the today's CPD program, Ms. Nahida Ahmad and Ms. Dolly Sharma, for their presentation and talk. I also thank who helped me behind the scene, Mr. Mahesh PS, the technical assistant and RSO in Department of Imaging Science, Sri Chitra Tirunal Institute. I also thank Ms. Samyukta and her team for the technical support. Thank you all for listening to my talk. Have a great research.
Thank you, Shashiji, for such a knowledgeable sessions, various means and approaches of the CT contrast examinations, and it's valuable for us. Now, I would like to invite our second eminent speaker, Mrs. Dolly Sharma. Dolly Sharma is Assistant Professor and Head Medical Imaging Technology at Chartori Institute of Paramedical Sciences, Gujarat. She is having 10 years of experience and presently pursuing PhD in diffusion tensor MR imaging from Gujarat. She is having more than 14 research papers in national and international journals, and professionally she is very active with the ISRT. So she is today going to speak about CT dose reduction techniques. I welcome you, ma'am.
Good evening, everyone. The topic I'm taking today is CT dose reduction techniques. CT is, when we are doing the CT scanning, we have to be very careful of certain parameters, okay, that I am going to discuss today. Apart from this, there is an increase in the number of CT examinations, which we are doing every day, and we are not paying attention, but there are associated risks, okay, with the CT, which increases the radiation dose as well. Okay, so I'm going to discuss all those things today. So first thing is, when we are doing the CT examinations, we have to see that there are some ways in the CT, okay, which are there to quantify the radiation output. For example, okay, CT dose volume. Okay, so basically the CT dose volume or CT dose information or CTDI volume, it gives you information how much radiation is received by the patient during an examination, but it is not a standardized way. These are just the reference values which are measured by scanning two phantoms. That is, one is 16 centimeter head phantom and 32 centimeter body phantom. Okay, so it gives the reference value that how much radiation dose could be delivered to a patient during specific examinations or a particular examination. Apart from this, we need to know that the organ dose and sex-specific risk data, okay, is also recommended to quantify the radiation dose which is related to the patients or the organs undergoing the CT examinations. So we usually measure the effective dose, which is expressed in the terms of millisievert, and it also allows us to compare the radiation dose and its induced risk among the different types of examinations. So if you see the effective dose of one part or the other part, okay, you will see the difference, how much radiation dose is delivered by a patient during the head scanning or during the chest scanning or the abdomen scanning. So effective dose is also one of the important parameter which shows you how much radiation dose could be delivered to a patient during a specific examination. Okay, so this is the table, okay, which shows, okay, the daily radiation dose which is delivered to the patient during the common examinations. Like head, it is 1 to 2 sievert, 1 millisievert, the chest 5 to 7 millisievert, abdomen 5 to 7 millisievert. Okay, so this is just a table, okay, which gives you an idea, okay, how much radiation dose is delivered to the patient during these common examinations. And the highlight is the background radiation, which patient is getting around 3.11 millisievert. So we need to be careful. The other thing which is very important whenever we are trying to reduce the radiation dose is the image quality. Okay, ideally image quality should not be sacrificed in order to maintain the radiation dose, but it has to be maintained or it has to be balanced. Okay, so one thing whenever we are trying to understand the radiation dose, okay, and the relation and its relationship with image quality, we need to see some some metrics, okay, which are responsible for the image quality. One is noise, okay, high contrast resolution, high contrast special resolution, low contrast special resolution, contrast to noise ratio, and signal to noise ratio. So these are the metrics, okay, which ultimately define the image quality. Okay, so I'll just give you the few examples, okay, how we can manage all this. So first thing, okay, whenever we are trying to reduce the radiation dose in order to maintain the image quality, we have to look into two perspectives. One is appropriately define the target image quality for each diagnostic specific task, or not requiring whether you need a higher dose or a lower noise, or higher specialism or a contrast resolution, higher specialism necessary. Okay, so whenever we are seeing the image quality for any of the tasks, for any of the examinations, okay, we need to see where we need a higher noise, where we need a lower noise, where we need a higher special resolution, or where we need a low special resolution, because basically those are going to affect your radiation dose. For example, if we do a CT colonography, okay, there it needs a detection of two things. One is soft tissue which looks like a polyp, okay, from a background, and there is layer and a contrast tagged stool. Okay, so here the noise level is allowed to be very high and the dose can be relatively low without sacrificing the diagnostic confidence, because here we are going to get the detail of the background air and the contrast tagged stool. So apart from this, the things could be ignored. The next thing is the liver and the pancreas. Okay, so the exams, okay, which involves the scanning of the liver and pancreas, we need the detection and characterization of very low contrast lesions. Okay, so there we can keep the noise level low and the radiation dose high. Okay, but we can reduce it. Okay. Now, apart from this, okay, it's a very challenging role, okay, to look onto all these parameters and increase or decrease this. It changes according to the observer preferences. It also changes according to the scanners. Okay, and it also depends upon the consensus agreement, okay, which requires that image quality do exist in the form of guidelines or the standards, although there is no precise quantitative requirement. So coming to the coronary artery calcium scoring, okay, which is an example, okay, where the target noise level do exist. Okay, so there we have to use a method. Okay, so there we can use the CTDI weighted CT dose index weighted and CTDI volume, okay, to quantify or to standardize the radiation dose, which indirectly also defines the target image quality. So basically, whenever we are doing a coronary angiography, we always have a reference values of CTDI weighted and CTDI volume. Specifically the CTDI volume, which is available in the milligram. Okay, so we can see the reference values, okay, how the reference values are changing and how much reference values we are getting at a particular image quality, and then we can define the target image quality. So coming to the diagnostic reference values, okay, these diagnostic reference values do not directly indicate the radiation dose, okay, delivered during a specific diagnostic task, but they are just the reference values. That means this much radiation dose could be delivered to a patient during this examination or the data examination. So these reference values for some common examinations is also established by the European Communication and several members of its state, as well as the American College of Radiology for the adult head, for adult abdomen, and the pediatric abdomen. So I will just show you this table. Okay, so here you will see that CTDI volume, CTDI weighted or CTDI volume, okay, the reference values for the adult head, for the adult abdomen, and the adult pediatric is already given. Okay, so we can also take this reference values in order to maintain the radiation dose at the image quality. The second perspective on the radiation dose is to improve some aspects of image quality. For example, we can reduce the image noise, which can be implemented to allow the radiation dose in reduction. Okay, so basically you can also reduce the noise. Then the other thing is that by optimizing the CT systems, scanning techniques, with, for example, the image reconstruction methods and the data processing methods. Okay, so these daily changes. Okay, whenever we are doing a CT and when we are sitting on the CT console. Okay, so we can do some small changes in our scanning techniques, in our image improvement system, or in data processing system. Okay, so now I will share with you the general techniques, okay, which we can with which we can reduce the radiation dose in CT. So there are some factors which are directly responsible for the radiation dose. There are some factors which are indirectly involved. Okay, so if we look into direct factors, there are exposure techniques. Okay, that means the millisievert, the KVP we are using, the X-ray beam collimation, like how much collimation we are keeping, the pitch, patient setting, number of detectors, and overranging. Okay, so these are the factors which are directly responsible for increasing the radiation dose, and there are some factors like reconstruction filters or the reconstruction techniques which are indirectly increasing the radiation dose. So coming to the detectors, okay, so detectors is basically the radiation dose depends upon the performance of the detectors also, and there are the two characteristics of detectors. For example, quantum detection efficiency and geometrical efficiency, okay, which together describes the effectiveness of detector work, or how frequent or how good it converts the incident X-ray into signal. There are solid state detectors, okay, which are widely used in place of the xenon gas detectors in 1980s, and nowadays because they are having the higher quantum detection efficiency. So detectors with rapid response and low afterglow are desirable, which allows the fast scanning speed and high image quality. Such example is the photon counting detectors, okay, which increase the high count rate capabilities available on the scanners, and it improves the dose as well as it improves the image quality as compared to the conventional detectors. The other thing is collimation. Collimation defines the beam width during the examination. Okay, it also reflects the efficient use of X-ray beam at the detector. So here, if you see the two images, one is 5 mm and the other one is also 5 mm. So this is single slice detector and this is multi-slice detector. So here, if you see the X-rays are falling, X-rays having a fan beam geometry and falling on the detector. Here, if you see the X-rays with a fan geometry falling on the multiple detectors. Okay, so if you see the radiation dose, okay, delivered during the single or the multi, it's falling with the penumbra. Okay, penumbra is the shadow effect. It doesn't produce or it doesn't affect the image, but it increases the radiation dose. So we need to be very careful, and we need to remove this penumbra. Okay, that is increased by that could be reduced by increasing the infinite number of detectors. The other one is FOV and filters, that is field of view and the filters, the types of filters which are used in the X-ray tube, okay, or the machine. Okay, so we need to choose the small FOV, okay, whenever we are scanning the part. So according to the part and its area, okay, we can define the FOV. Okay, apart from this, there are some filters which are provided by the vendors. For example, the Bounty filters, okay, which reduces the radiation dose by 50% and reduces the noise and the artifact also. The other thing is overranging, okay, in Z direction, okay, or in Z axis. Okay, so whenever we do the scanning, what we do is like we take some additional rotations before and after the planned length, okay, which is essential for the image reconstruction, but we should not increase it more. Okay, we should not create much length before and after the planned length, because it will increase the radiation dose to the patient also. So unnecessarily, the patient is going to get exposed. For example, whenever we do a chest scanning, okay, what we do, we increase the length below also. We include a little part of lever also, though it is not required. Okay, so we need to avoid this. The other thing is patient centering. Okay, so we have to see, okay, whenever we are scanning the patient or whenever we are putting the patient in the X-ray, the CT, okay, you need to see, okay, the proper centering, okay, or how much area we need to scan. The planning has to be very accurate, okay, which will create a good image quality, as well as the unnecessary radiation dose would be avoided. Now, one of the good thing is automatic exposure control, okay, which is very common method nowadays, okay, which adjusts the X-ray tube according to the patient weight or size-based protocol. Okay, during this method, what happens? The patient size and the weight is measured, and the appropriate tube current modulation is applied from a chart, okay, where the tube automatically modulate the current according to the patient, according to the attenuation due to the patient anatomy, shape, and the size. Okay, so it's having the two methods. Okay, one is angular modulation, and the other one is longitudinal modulation. Angular modulation is the X-ray tubes adjust the tube current in the short axis, and longitudinal is along the long axis of the patient, that is Z-axis. So here you can see in this figure, okay, so if we see the tube current, and this is the table position, okay, so according to the thickness, so if you see this abdomen scanning, the thickness of the patient is varied. So it requires a different amount of tube current. So this tube current would be adjusted according to the thickness or size or the shape of the patient. Okay, so this is the table, okay, which is just representing the name of the AEC controls, automatic exposure controls given by the different manufacturers or the vendors. Okay, in case of GE, the name is as a Auto MA, Smart MA. Okay, and the image quality references noise index. Then Toshiba is having a Shore exposure. Siemens is having a clear dose 4D, and Philips has a dose right. Okay. So all the goal of all these automatic exposure controls is to maintain the noise level, okay, which is ultimately defining the image quality as well as the radiation dose. Now, what are the advantages of dose modulation? One is it is more consistent. It provides a more consistent signal to the detectors, so there would not be any variation in the amount of photons or the signals received by the detector. Then image quality is maintained at a good level or a constant level. Then the tube heat capacity could be saved or conserved. Okay, and there's a reduction in the photon starvation or the streak artifact. Basically, the variation in the number of photons reaches to the detector. Okay, that is also reduced here. The dose could be optimized, and the dose is reduced around 10 to 50% and able to set the reference or the noise values. Coming to the exposure factors, okay, so one is the KVP, the tube current exposure time. So ultimately your KVP and the MAS, okay, sometimes there are default settings available on the machine, but we can change it, okay. So whenever the patients are coming, okay, according to their age, height, or according to their age or the weight, okay, we can do these changes manually. So we can increase the KVP or decrease the KVP, increase the MAS or MAS or decrease MAS, so depending upon the situation. So here also the technologist can also set these factors manually, or if not, then they just select the automatic exposure control, okay, where the automatic exposure controls defines the radiation dose as okay. The other one is constant milliampere, that is your MAS. Okay, so there is a selection or there is a selection of MA or the time separately. Okay, so here also, okay, you can decrease or increase the MAS, okay, which ultimately defines the quantity of photons incident on the patient for a particular duration, and for how much duration, that is your seconds. Okay, your time defines that. The next is dose is directly proportional to milliampere second. So if you increase the MAS, okay, the dose also will be delivered. So there is a direct relation between MAS and the dose. The other one is kilovoltage. Okay, so kilovoltage is basically defines the penetrating power of the photons from the X-ray tube. Okay, so if you increase the KVP, okay, the penetration power or the energy of the X-rays will also increase. Okay, so we usually we keep 120 kVp for the adult scanning. Okay, and radiation dose is proportional to the square of kVp. So if you increase the radiation dose, so here the kVp, sorry, if you increase the kVp, the radiation dose also will increase the 4 times. Coming to the pitch, okay, so pitch is the distance or the table increment per rotation. Also, sometimes the beam also defines the beam collimation. Okay, so there is an inverse relation to the radiation dose. The pitch is having an inverse relation with the patient dose. So if you keep a larger pitch, okay, the radiation dose will be low, the scanning time will be faster, more image noise, and the decreased resolution. The number of detectors, as we discussed, okay, the measured radiation dose is inversely proportional to the number of detectors. So if we increase the number of detectors, the dose will decrease. Coming to the rotation time, so rotation time is having a linear relation with the radiation dose. So here also, if you increase the rotation time, the radiation dose will increase. If you decrease the rotation time, the radiation dose will increase. Okay, so here the linear decrease in the dose, okay, it allows the faster scanning time. There would be less motion and the breathing artifact, and use short rotation time, especially for the pediatric patients. Okay, so the last technique is the last thing I would like to tell is the pediatric patients. So whenever the pediatric patients are coming, okay, so we have to be very careful with the protocol we are using. Okay, how we are going, the process, okay, of taking the patient inside and outside the machine also, we have to be little careful. So before we scan the patient, before we take the pediatric patient in the CT, okay, we have to see, okay, if there is any other alternative exam, okay, or alternative diagnostic method, okay, which could be used for pediatric patients, okay, in comparison of CT. Okay, apart from this, we have to use KVP or the MAS as low as possible, okay, during the pediatric patients, and multi-phase examinations we should avoid, okay, during the scanning of pediatric patients. The other thing is the cardiac CT. Okay, so cardiac CT is nowadays, okay, because if you see a coronary artery or the cardiac CT, usually, okay, needs a more radiation dose, because there we need to maintain the image quality also and the radiation dose also. So now if you see, there is a significant reduction in the helical. Whenever we are using a helical scanning, okay, there is a significant decrease in the radiation dose, because now there is ECG tube current pulsing, okay, where the ECG is followed by the ECG cycle is followed by the tube current. Okay, so where your X-ray tube will stop, X-ray tube will on and off according to the ECG cycle. That means it follows the heart motion. Okay, so there are the scientists, okay, which assess that the optimal width and the timing of the ECG pulsing window at different heart rates, okay, could be followed, okay, and achieved up to 60%, 64% of the dose reduction. Okay, coming to the summary or the future perspectives, okay, that means that the radiation dose can be decreased, okay, depending upon the patient's attenuation level and anatomic structure and clinical indications, which is already improved by the automatic exposure control. Still, we can select the appropriate tube potential and the KVP. Apart from this, okay, there is some methods like computational methods, the iterative reconstruction, which can also be implemented in daily practice, okay, and improves the substantial image quality as well as the radiation dose could be delivered compared to the previous methods like filtered back projection or the back projection. Then apart from this, the advancements in the detector is the photon counting detectors, okay, which sufficiently improve the counting capabilities, improving the radiation dose, improving the image quality, and decreasing the radiation dose compared to conventional techniques. So here I'm done with my presentation. Thank you so much, and I'm thankful to ISRT to providing me a platform worldwide or globally. Thank you so much, everyone. Now you can ask the questions.
Thank you, Dolly, for very informative session on CT dose reduction technique. Definitely, CT is having major contribution in radiation doses for medical exposure, and it needs to be minimized in every possible way. And this talk going to help a lot. Now, I would like to invite our third eminent speaker, Mrs. Naida Ahmed. She is graduated from Rajiv Gandhi University, Bangalore, and presently working as a lecturer in diagnostic technology at Government Medical College, Anantnag. Naida is very active in regional activities with ISRT. She is presently the regional coordinator for ISRT and professional and development secretary for ISRT JK region. Today, she is going to speak about women imaging in radiology, critical findings. The floor is open for you.
Good evening, good afternoon, and a very good morning, everyone. Thank you for attending this session. I would like to thank the organizing team for giving me this wonderful opportunity to present on this platform. I'm Nahida Ahmed, working in the Department of Radiology as a radiological technologist cum tutor in Government Medical College Anantnag. Besides this, I'm the governing body member of ISRT India and a professional and development secretary of ISRT Jammu and Kashmir chapter and ISRT Srinagar Academic Club. Today, I'll be talking about the women imaging with some of the critical findings, even though there are a lot of critical findings, but we will be talking about very crucial findings which are life-threatening and need to be treated as soon as possible so as to save the patient's life. This women imaging is a vast subject. However, in the given time, we will be able to give justice to some of the medical emergency. Before proceeding with the session, I need to mention in India, we are not allowed to do the ultrasound, but if you work outside India or any country, any country other than the India, you are called as a sonologist, and you should know or you should have the knowledge of these critical findings, because the first choice of these critical findings is always the ultrasound. That is how you need to get trained and have the knowledge of these critical findings. And those who hear me from India, please make sure that you follow your country guidelines. We have an act called as an PCPNDT Act, which is Preconception Prenatal Diagnostic Technique, which prohibits of sex selection before and after the conception. So please make sure that you follow your country guidelines. So in this session, we will be talking about the ovarian torsion, congenital abnormalities of the fetus, and ectopic pregnancies. This ovarian torsion refers to the rotation of the ovaries to such a degree as to occlude the ovarian artery or vein, which blocks the blood circulation and land up in the life-threatening condition. And sometimes we may lose the life of the patient if not diagnosed early. And even if it's diagnosed early, but medical intervention is very late. So that also leads to a life-threatening condition. The first choice of the modality for this condition is always the ultrasound, until and unless there are certain circumstances like any technical error or the radiologist is not available, or anything which will not allow us to diagnose these patients in the ultrasound. This diagnosis gets shifted to the secondary or the tertiary modality, which we have in either the CT or the ultrasound. If you see this image, here you can see the normal right ovary and the uterine cavity, and you can see the left ovary which is bulged, or you can see the torsion and twisting of the left ovary, and which is a classical condition called as an ovarian torsion. And these patients come with the clinical presentation or the clinical history of the abdominal pain, nausea, and vomiting. And these are the classical symptoms of the patient with an history of the ovarian torsion. And this patient, if you diagnose it in the ultrasound, you can see the image. This is the image of the right ovary, and the same patient with the image of the left ovary. You can see the right ovary is completely fine in diameter, and the blood flow is also fine. But if you see the left ovary, you can see that this ovary is quite enlarged, with the peripheral displaced of the follicles, and in center you can see the ground glass appearance of the central follicular stroma. So this gives the classical clue of the ovarian torsion. And this patient has come with the clinical presentation of pelvic pain, and this patient was diagnosed in all the three modalities like ultrasound, CT and MRI. And initially, this patient was detected with adnexal mass on ultrasound and CT, and later it was confirmed as ovarian torsion when examined in the what we call MRI. This ultrasound image showing in a heterogeneous mass with cystic appearance in the left adnexal, showing no vascularity in the color Doppler, and in CT image, you can see the heterogeneous hypodense mass in the region of the left adnexal with an area of this cystic appearance. And the patient, when examined in the MRI, we see an T2 weighted image showing an heterogeneously hyper-intense left ovary with 5 enlarged follicles in its periphery, and the T1 weighted image showing hyper-intense signal of ovarian stroma, suggestive of the hemorrhage. This confirms the ovarian torsion. So these kind of conditions, like in ovarian torsion patients, sometimes some of the cases gets rectified in clinically, and some patients need to get to be treated by surgically. And if you see this, this is an image of the intraoperative patient. Here you can see the uterus, you can see the ovary, and the what we call as a twisted ovarian pedicle. And this patient was successfully detorsioned by the laparoscopic surgery. And as I already mentioned, that the choice of the modality is always the ultrasound, and until and unless there are the findings that or some other issues that need to be rectified or by CT or MRI, we can see in CT but this evidence of subacute ovarian hemorrhage or abnormal enhancement with IV contrast agents, it's also highly suggestive of torsion. And knowing these characteristic features of CT or MRI, the radiologist will be able to recognize torsion in women being imaged for acute pelvic pain if the diagnosis will be missed or has been missed in the clinical evaluation. And second, we will be talking about the congenital abnormalities of the fetus, which is done by the anomaly scan, and ultrasound has been the preferred modality for fetal anomaly detection for several decades. And the standard 20-week scan has been considered the most crucial imaging in this procedure. And through scan at this stage can identify a majority of the structural anomalies. And a fetal magnetic resonance imaging may be indicated either because of the fetal or maternal factors, such as elucidation of an anomaly, which is already detected by this ultrasound, and suboptimal ultrasound scans because of poor acoustic window or maternal obesity, and uroplacental pathologies such as fibroids, abdominal placentation, or congenital uterine malformation. So what are the indications for anomaly scan? Usually these scans are done for all the pregnant women, and the pregnant women should be offered 2 scans in pregnancy. The first has to be in 11 to 13 weeks, and the second around 20 weeks. And the importance of this diagnosis is to get into the conclusion whether the pregnancy needs to be terminated or not, or the fetal therapy need to be done. So these are the importance of the diagnosis, whether it be it in the decision of terminating the pregnancy or not, or either the fetal needs to get into the procedure called the fetal therapy. And if you see, there are 2 images on the right side, which is a normal fetus, and the left side you can see the some of the abnormalities here. If we see in the this normal fetus, we can say this is the fetus. This scan was done in the first trimester. Here you can see that the nuchal ligament is at this nuchal thickness is at the what we call in the normal diameter, which is less than the 3 mm. And if we see in the left side, the nuchal thickness is increased, which is greater than 3 centimeters. So this is the soft marker of the condition called as the Down syndrome. And the second thing, if we can observe here, is there is the hyperintense kind of thing, which gives the confirmation for the nasal bone. And in this image, we are not able to see any hyperintense, which is seen in this image. So this is also one of the clue of the condition called as the Down syndrome. And this is the 9-week fetus, a transvaginal scan with no extremities, and instead of the rounded cranium, we see a very irregular shaped cranium, and this is the dystrophic brain tissue which develops and protrudes out from the skull where the cranium bone has to be, and this gives the confirmation for the condition, for the anomaly called as anencephaly. And if there are the anomalies which are seen in the scan, but those anomalies can be treated after the delivery of the fetus. And but this procedure, these kind of procedures needs an pediatric surgeon at the time of the delivery. You can see that there are 2 images. The one on the right called as omphalocele, and the left on the left image, this condition is called as gastroschisis. This omphalocele has a mass in the abdomen which is enclosed by membranous tissue, and it has protruded out of the abdominal cavity. And in the right side, gastroschisis, we can see the intestines and the other abdominal organs have protruded out from the abdomen, and without any protection or the membranes. So these kind of situations can be handled after the birth, and you can see this these gets rectified by the surgical procedures, and this is how these kind of situations can be rectified by these surgical procedures. So now we'll be talking about the ectopic pregnancy, which is the alarm or the life-threatening conditions. This is the condition where the pregnancy happens outside the uterine cavity, which normally the normal pregnancy happens within the uterine cavity, but in ectopic pregnancy, the embryo becomes implanted at a site other than the normal uterine cavity. And this ectopic pregnancy has an incidence of approximately 2% of all reported pregnancies and accounts for 9% of all pregnancy-related deaths. Here you can see this is the image of the normal pregnancy with fertilized egg implanted and normal fallopian tubes, normal ovary. And the other image, you can see the fertilized egg has been implanted to a site which is not the normal site for the pregnancy. So this is the condition called as an ectopic pregnancy. And this site to which the embryo gets attached, the ectopic pregnancy has been divided into many types. You can see these are the different types of the ectopic pregnancy to which the embryos are attached. If you see, the ampullary contributes the major percentage of the ectopic pregnancy. It accounts for 70%, and you can see the ischemic, it contributes to 12%, and then comes the fimbrial, which accounts for 5%, and ovarian ectopic pregnancy accounts for 4%, corneal accounts for 2%, and abdominal, cesarean, and cervical accounts for 1% individually. So this is the condition, these are the types of the ectopic pregnancy, as the embryo is attached to different locations, and the clinical representation or the indication of these patients are mainly the abdominal or the pelvic pain, and nausea and vomiting. In the we can say the vaginal bleeding is also a clue to this ectopic pregnancy, and the patients can have dizziness or fainting or even the loss of appetite also. So this is the only present only in this kind of indications are present only in 40% of the patients, and up to 30% can have no clinical symptoms at the time of the presentation. So this is our role, how to help these kind of patients at this kind of situations. And the risk factors for the ectopic pregnancy would be always surgery, pelvic inflammation disease, and the endometriosis. And when the patient comes for the clinical evaluation of this kind of situation, first we confirm it from the positive HCG, and then the transvaginal ultrasound plays the role. And sometimes there is we don't have any idea what this site is. Here is the role of the transvaginal ultrasound, which helps in the diagnosis. And in gestation longer than 5.5 weeks, a transvaginal ultrasound examination should identify an intrauterine pregnancy with almost 100% accuracy, and approximately 25 to 50% of women with an ectopic pregnancy initially present with pregnancy of unknown location, and approximately 7 to 20% of women with a pregnancy of unknown location ultimately receives the diagnosis of the ectopic pregnancy. And this ultrasound is an excellent tool of evaluation of ectopic pregnancy. Like if we see that see an ovarian adnexal mass, you can be confident in making the decision of the ectopic pregnancy. And however, in about 25% of the time, ectopy is not seen at the time patient comes for first trimester and in early evaluation of pregnancy. During that time, follow-up is recommended, and with the necessary or with the complete follow-up, the diagnosis can be made. Because just as a normal intrauterine gestation will grow so well in ectopic pregnancy, and with the help of the follow-up or follow-up scans, a diagnostics can be made very well. And if we see that this ultrasound shows positive findings in almost 95% of the cases, and the common finding is adnexal mass, non-specific mass also, and you can see the yolk sac, and even sometimes the live embryo also, because even though this is less in these days, as the patient is scanned earlier and the diagnosis is made very well. And here, if you see, this is the patient. Here you can see this is almost the 5 centimeter of the heterogeneous, or we say the circumscribed mass, and with some heterogeneous in the left adnexa, and the patient with nothing in the endometrial cavity. And you can see there is a little bit of fluid and is a non-specific adnexal mass, and thus proves the patient with a positive ectopic pregnancy. And once the diagnosis is done by the ultrasound, what is next? The this management has been triaged into 3 categories. The first will be the expectant management. The second one is the medical therapy, and the third one is the surgical therapy. This expectant management is if the HCG levels are low or decline, or the patient is clinically stable. This can be just followed expectantly, and then the other categories is the like if the adnexal mass is less than 4 centimeter, and the HCG level is also decreased, like less than 15,000, and the patient is clinically stable and is able to complete the clinical follow-up. These patients can be treated by medical therapy by prescribing intramuscular injection by the doctor, and then the surgical therapy, because in some cases, however, like early example of a young woman, the emergency that is an emergency with the severe pain and all these symptoms like severe pain, peritoneal signs, hemoperitoneum by ultrasound, and moderate or large volume, and we can even see the falling of the hematocrit, and HCG level is also greater than 15,000, and the adnexal mass or the ectopic size is also greater than 4 centimeter. These kind of patients typically has to be treated surgically. And if you see, this is the excision of ovarian ectopic pregnancy. Here you can see the ovarian ectopic pregnancy, and this is the right ovary and the right fallopian tube. So this patient was treated successfully by the surgery, and the management was done in a proper way. So this was all about my presentation. Thank you so much. If any questions are there, I'm allowed to answer. And if anyone wants to get touched regarding this presentation, I have provided my mail ID. Please get connected through this mail ID. Thank you so much.
Thank you, Naida ma'am, for a very informative talk. All the speakers, definitely these kind of talks will help us a lot. Now, after the conclusion of the lecture session, I would like to ask some questions on behalf of our audiences. So there are some questions for different speakers. Firstly, I would like to invite Sashi sir.
Yeah.
So some of the queries, so we should discuss or answer about, if it is okay. So Purva Saran sir, Raju want to know that how we can use higher concentrated contrast media to all the patients. This technique could be normal for renal function. And another question he is having, that is that ideal thing to give 125 ml of contrast per patient?
First and most, thanks for the questions. Always after the presentation, the doubt should be cleared. The first question is asked by high concentration contrast media. Could be used for normal. Yeah. We don't use it for all the patient. Particularly, it is only depends on condition, depends on this thing, only we will give it. Whatever I given example in my study, that was in my presentation, that was to find if it is we are using a different concentration with the 300 or 350, 370 or 400, what will be this thing. In regard to the other question which is asked about 125 ml, contrast medium with a larger concentration delivers a larger dose of iodine, is in a faster, and the result also, it means the magnitude of the peak of the contrast is quick, is faster. So that sometimes we wanted to have the wider window of the CT imaging to in a given enhancement. We wanted to have the particular arterial phase with the wider window of the CT scanning imaging. For that time, we will use this 125 ml, but or else as a practically 125 ml are not given in, maybe I can say that I've seen a lot of studies where 125 ml usually in Asian countries are not given. Maybe obesity with the higher obesity or hefty patient, body weight more than 100 kilo. If it is such condition, 125 ml will be given in case if you're doing angiography. Yeah, next question, sir. Can you unmute?
Yeah, sorry. Yes, correctly said, sir. That depends on many more factors, body weight, patient conditions, aim of the pathological examinations we want to conduct. So there are many contributing factors to decide the quantity of the contrast media and many things. And I think is the answer for the Rajesh sir. Now, Damodar Naidu Kotti want to ask the comparison between radiation doses and the voltage.
Yes, sir. Definitely, it's a good question. And also, one more person also asked, low voltage decreases radiation dose. Is it correct? I think I wanted to answer for both of them. The benefit of the use of the lower voltage, it has been recognized in usually in pediatric CT or some of the adult CT applications also. Recently, we have that advancement in CT. So the main what I have shown here, the amount of contrast medium where required is substantially is less when we use lesser tube voltage. Means I give an example there in a graph. If 80 kVp when compared to the 120 kVp, where the degree of the enhancement is same. When you use a lower kVp and the higher kVp, when you make the variations of the iodine per milliliter, when you use that combination with the lower voltage, we can have good enhancement equal to 120 kVp. So that, see, this is something how you might be thinking, how this radiation doses decreases. All of you know that, all of you studied very well. As the contrast amount is decreased to patient, the radiation dose also will decrease. That's a lot of studies is going on. When you introduced me in the beginning, I'm doing study in biodosimetry. The similar study I recently had done, where in the plain scan and the contrast scan, where we have seen that there is a lot of using 350 mg, maybe 370 mg, there is a radiation exposure to patient is absorbed by the patient body will be vary. So of course, when you use a lesser iodine, definitely the radiation doses decreases. Thank you. Next question, sir.
Yeah, thank you for answering. Another question from Yun from Myanmar, that contrast testing and consent. Please let us know that the concentration uses of 350 mg per ml or 370 mg per ml depends on age, case, body weight, or the tube voltage. How many kinds of contrast are being used in India?
Yeah, that's a very good questions, because the intravenous contrast media were commercially available in a wide range of concentration, usually 240 to 370 mg of iodine per milliliter. In India, the selection of appropriate contrast medium is the concentration depends on the multiple factors, sir. Maybe availability of the contrast media. Certain places 350 mg or 370 mg only used. We are not able to have the maybe 300 mg, those things and all. It's not available here. Sometimes clinical objectives and depends on radiologist prefer. Maybe sometime one of the important factors is due to CT scan configuration, maybe injection rate, and the last one I like to tell the cost, because especially when we do scan here, and we will mainly concentrate the cost of the amount paid by the patient when they purchase contrast. That's we will consider all these points. Thank you for the questions. Next question, sir.
Yes, sir. Thank you. Another one is Puto from Indonesia. So
Recording in progress.
I want to ask that what is the conditions of the patient that requires the administration of 0.25 ml of the contrast medium as shown in the concentration versus enhancement ratio in your slide, sir?
It's a very good question. I really, whoever asked, I think he or she has a good interest in research, I feel, because it's a fast injection would be better suited for faster scan. Sometimes the scan timing is very precious. Example, if you're taking pulmonary angio kind of thing, we wanted to have the increased contrast is an increased fixed volume contrast medium should be given so that we'll have the peak of enhancement of the contrast enhancement, that magnitude, it should be occurs earlier, and it should be that finish that scan within that time limit. If you have a 1 second of delay might be, or early might be, will cause the getting the exact arterial phase might be vary. In case sometime decreases, what will happen? We might be sometime wanted to have the CT window wider, so that time we will use the decreased contrast injection, so that we can have the scanning time wider, and we can cover the more area what we required. I think I answered well to the question what he asked. Thank you for the question once again.
Yes, sir, probably be the right answer from Potu, sir. Another question from Mahesh Jagtap that he want to know when contrast delay increase or decrease.
I think that question I answered right now, sir.
Okay. Yeah, it's one of the cumulative answers. So another one is Purva from Pari that want to ask if we cannot perform IV administration from right-hand side axis. For example, if we inject the contrast media from left-hand side or from lower extremity foot, what should we do to maintain the contrast enhancement?
So as I give an example during my presentation, is always better to use right side. In case if it is not possible to provide the cannula at the right side, if you are injecting from the left side, increase the flow rate. The flow rate might be 0.2 or 0.3 ml per second. If it is example right side, if you are giving 3 ml per second, if you are giving left side, increase the flow rate 3.2 ml per second. That could be the better suggestion I give from my end.
Yes, sir. Thank you for clearing the queries, and might be it's clear to everyone.
Yeah. Is there any other question, sir?
Helps a lot. I think there are these questions from for you. Now I would like to move towards Ms. Dolly, ma'am.
Thank you. Thank you so much.
Okay. Yeah. So may I request the panelists, if they have the queries, Shashi Kumar Shetty is here to answer the queries. If anyone to add or suggest, you are invited. I think, sir, we now move towards Dolly ma'am, sir. Yeah. Hello, Dolly ma'am.
Yeah, hello, sir.
Yeah. So thank you for the nice presentation. And also we have some suggestions and queries from our audiences. I would like to ask a query from Damodar Naidu Kuti that he want to ask that in slide you are telling low voltage decrease radiation doses. Is it correct?
Yeah, sir, it's correct. But you have to specifically see the exam and first the exam. Okay, which exam you are doing? whether you are doing a contrast exam or you're doing a non-contrast exam, then the type of patient you are using, whether you are using an adult patient or the pediatric patient, so you have to change. Okay, now automatic tube current modulation is already there. So we don't have to. So we can we can just click on the automatic tube current modulation and the things would be done. But if not, then we have to do that manually. Okay, we have to change the images. Otherwise, it will definitely increase the noise and the image quality also would be affected. I hope I have answered. Or
probably yes, ma'am. And now the Puttu sir want to add something into your talk.
Yes.
That he is telling that I think those audits is important as modifying exam parameters through the regular evaluation of the radiation doses delivered to the patient and comparing it to recent standards. DRL for CT examinations can be optimized.
Yes, sir. It can be optimized, sir. Like now quality assurance tests are also done. Like sometimes, somewhere annually, somewhere it is 2 times in a year. So there, we can just see the DRLs and optimize accordingly.
Yeah, definitely. DRLs are the highest standards that one can give.
Yes.
So we can, by a process of optimization, is always welcome to reduce lower doses as prescribed in the DRL. So definitely it's good. So that's all queries from the audiences. Right, if any of our panelists or the audience want to ask live to Dolly Sharma ma'am, they are invited.
Yeah, please you can ask me.
Yeah.
Is there any question?
So, I think there is all from your side. And now I want to move towards next speaker. Thank you, ma'am, for being with us and
thank you, sir.
For a nice presentation. And definitely it helped a lot for us to minimize the radiation doses and finding the ways to how to reduce the radiation doses from the CT examination. Now I would like to invite Ms. Nahida, ma'am.
Nahida ji, can open your mic.
Okay.
Thank you.
Yeah. Can I have the questions, please?
Yeah, ma'am. Thank you for nice presentation.
Thank you.
It's definitely it's about the woman imaging and woman focusing today you are. So some of the queries we have from our audience, Purva sir and Raju want to know which imaging modality is ideal for diagnostic or the ovarian torsion.
Okay. As you already said, the best modality, if we talk about the women torsion, is always the ultrasound. And then it depends the availability of the modalities you have in your hospitals, because it differs from different hospitals. So the best modality is always the ultrasound, because this is the emergency and the patient has to go to the quicker diagnosis, which is the ultrasound, and low cost, and the radiations is not there. And if somehow, if any circumstances are there where there is the ultrasound is not available, then this modality or the diagnosis can be shifted to the CT or the we call CT screening or the MRI screening as well. And sometimes these kind of things gets when we do some patients are coming which are coming for the abdominal pain, and incidentally that time also we get to know about these kind of what we say as the pathologies. So I would prefer that always the best modality is ultrasound, and if any circumstances are there where it's not available, so the diagnosis can be shifted to CT or the MRI for screening. Yes.
Yeah, ma'am, definitely it's be the answer for the queries. And also, Jasid and Telly want to congratulate you for the informative and nice talk, and many other audience also congratulated
Thank you.
for the very optimized talk. Now, I request to our panelists or the audiences who want to ask.
I think there was one more question for me, hepatic pregnancy, right? Someone wants
Yeah,
to know
right.
about the hepatic, pregnancy, liver pregnancy. I think, yeah.
Yeah.
So I would love to answer this question as well. This hepatic pregnancy, if we see this recently, there was a case of this. These are the rare cases we see in the radiology. So these are the uncommon conditions, and these kind of cases have the higher mortality. And the reason for them, this kind of patients needs to get laparotomy immediately. And the reason I believe for these kind of patients is the liver is the largest organ of the body, if we see, and also a great blood supplier, and this helps to meet the constantly increasing blood supply of the embryo. So that is the reason I believe that sometimes this kind of this hepatic pregnancy occurs. So I think
Yeah.
One
more question we also received, that if a patient having hydrated cyst, which modality would be better?
Hydrated cyst, usually we see them in the CT. If we see in the hydrated with the contrast, and sometimes because sometimes these kind of patients, we see the patient comfortability also, and the quicker diagnostics also, and these kind of patients also, and then shifted to the ultrasound also. And I believe that these kind of patients has the best diagnostic tool is the CT for hydrated cyst.
Yeah. Another from Anisa, but she want to ask about the CT abdomen or the CT triple phase.
Mm-hmm.
Might be she want to compare the modality, I think.
Sometimes it depends upon the need of the if she's talking about the same patient, she's a hydrated cyst patient.
Probably.
Okay, so even we do the triple phase also, and the abdomen as well. Depends upon the need of the radiologist also.
Okay. Another question from Heman Joshi, that he want to ask, many radiologists prefer MRI than CT for female pelvic scans, mostly cervical and the torsion cases. Do you want to comment on it?
Yes, if we basically this MRI, we see the safest modality if we talk about the women imaging. The first I said the line will be, they will always prefer the ultrasound, and then they'll go to the if they think about the radiation safety or this thing, so they'll shift it to the MRI. And then in this also our patients, because sometimes the patient will be very painful, and that time the patient has to be in the department for long as compared to the other modality. So that is also a drawback of this kind of modality. So this also depends upon the comfortability of the patient and how much the patient is comfortable in bearing the pain as well.
Yeah. One another query we received, that for pelvic pathologies, mainly in female patients, the MRI is better modality when we compared with the CT.
Correct. In terms of the radiation safety, that is true. And there also, like if we see the patients also, if we talk about the radiation safety and the safety of the patient, we always, especially of the females of the childbearing age, we prefer the ultrasound, which is free of the radiation. And then second choice is in terms of the radiation safety, is always as the MRI. So that is also the reason.
Yeah. Also, one queries we can take up, and we move towards our feature, that why single emulsion film is used in mammography, as we know that double emulsion film requires lesser exposure than a single emulsion film.
Is it for me or Shashi sir? Shashi sir, you would like to answer this question?
I think the single emulsion in mammography we are using single-sided screen.
Yes.
Yes.
Also, so there is no use of using double emulsion in mammography. Shashi sir, want to add?
No.
So I think that will just simply increase the cost. So it's better to,
Definitely. And also one query we received from Lalit Gupta sir for you, Dolly ma'am, for you.
Yes, sir, please.
Yeah, you want to know that diagnostic delay can be covered in API, especially in abdomen CT.
Sorry, I didn't get that.
No, that question was asked for me, sir.
Okay,
given information, not a question it is.
Yeah. So you want to comment on it?
Yeah. Using API, this diagnostic delay can be reduced. It's the recent advances, whereas adapting in many of the modality will be used. That's a good information from Lalit Gupta, sir. Thank you.
Yeah. So I think we have covered most of the queries.
And still, if you have any panelists want to have some questions, it's open for a few minutes, then Ichi ma'am can inform about next sessions.
So if any of our audience or the panelists from our member countries want to add something or want to have queries still uncovered, they can ask.
Then we can move to Miss Pichi Luna ma'am.
Yeah. So thank you for our speakers for being with us and having some very wonderful session, today's session. Now I'd like to invite Ms. Pichi Luna ma'am to brief about the future program of the ISRT Asia CPD.
Well, sure. Thank you very much to our moderator, Mr. Mukesh Jain. And the Indian Society of Radiographers and Technologists has just provided us with 3 great speakers, and from whom I'm sure we have learned so much from their very interesting, well-selected discussions. We would like to say thank you to our distinguished speakers, Mr. Shashi Kumar Shetty, Miss Dolly Sharma, and Miss Nahidia Ahmed. We have learned so much from your interesting and very important discussions. In the interest of time, we have to end and cut from here to give way for the closing session. But let me first invite Mr. Suresh Malayat for the vote of thanks.
Yeah, might be Malayat sir having low connectivity. He is in remote area. So I think, ma'am, you can announce the next CPD program. Then we'll.
All right, sure. So first of all, we would like to say thank you to President Selva Kumar of the Indian Society of Radiographers and Technologists, ISRT, our new member society for the Asia CPD. We would like to say congratulations to you and to all the officers and organizing committee of the 23rd CPD Asia. And we also would like to give thanks to our many sponsors and the VT Healthcare Vietnam. Also, we are grateful to our 3 great speakers. And most of all, we are sincerely grateful to all the member societies, presidents, our panelists, to our very much hardworking CPD Asia IT team, and to all our registered participants who have made this online CPD Asia program a success. Next month, it's a very exciting month because we hope to have the new board of the ISRT in the Asia-Australasia region to give us wonderful and interesting topics for discussion in April. So we would like to, again, hope to see you again in the next Asia CPD. Thank you, ISRT. Thank you, President Selva Kumar, and all our guest speakers and participants. Good evening.
Thank you. Thank you, madam. Thank you for your.
Thank you.
Thank you, sir.
Thank you, Pichilo, ma'am.
Yeah.
Suresh, you can conclude.
Suresh,
Yes. Any transactions of any questions remaining?
Yeah, still over now.
It's over. I heard. Yes. I think there is no need of a formal vote of thanks because I wish to express my sincere gratitude first to Mr. Mukesh Jain. He has wonderfully managed this session, a moderator, because he's a person I know. He's a person who practiced radiation therapy as well as diagnostic radiology for the past 25 years. He's well versed in both, and he's the first. I think he's the first PhD scholar in medical radiation therapy in India. So we have selected a very good person. I give a big salute to him, first of all. And second, to our faculty members, as I told in my at the time of opening remarks, we are grooming up a new generation in India, especially the faculty. This is a faculty development program also. Mr. Shashi Kumar, Mr. Miss Dolly Sharma, and a new emerging faculty as well as a leader from the Kashmir, Nahida Ahmad. I'm very happy to see how our community Indian radiological technology is developing and into a knowledge society and from the professionals to a knowledge society and to the academic community. I wish to give a big thanks to all the speakers who have done a very good presentation as well as a very good interaction. That is very important, interaction. And almost 500 delegates. Right now it is 420 or 418, 420. It reached 500, and from across India, across Asia. Most of the delegates are from Southeast Asia, I think, and from West India also. I give a big contrast to them. Their patient hearing and their very interactive sessions and very good interaction with the audience with the delegates. With the speakers. I think more than 30 questions we have received. And last but not least, I give my sincere extend my sincere thanks to Pichi Luna ma'am, who is the key person, and he is the person behind this coordination. She started that CPD Asia CPD forum
Recording
in 2020. Yeah. And all others from Indonesia, from Malaysia, from Singapore, from Mongolia, and all Asian countries, the presidents of all Asian countries and active members. I think this coordination will go ever, and we are looking forward for the I think we are a little bit late by time, almost 2 hours. And out of the 2 hours, almost 30 minutes, more than half an hour we have taken for interaction. It is a very fantastic thing. I have never I have never expected this type of interactive session in this program. I wish to express my sincere thanks to delegates. They have made this conference very interactive. Thank you all.
Thank you, sir, for kind words. Definitely, it's all your inspiration and encouragement which put this in this arena. And also, now I would like to thank all of our audience to being with us, their gracious presence. Thanks to our member countries, office bearers of ISRT, and our definitely the audiences. So it's many thanks to being with us, and we'll sure to see you again in next CPD program, CPD Asia. So I want to thank all, and now we move towards the conclusion. Thank you.
Thank you. Thank you all.
Thank you all the panelists and speakers, and the great support from all the participants. It's really a wonderful session. Thank you all for making this, and we'll meet in the next CPD. We are waiting for that. Thank you.
Thank you, sir. We thank all the faculties and delegates for being a part of this session. Special thanks to the organizers for organizing this wonderful session. On behalf of We Doctor, this is Sarita, Samyukta, Sumit, and Rekha signing off, wishing everyone a good night. With your permission, may I end the session, sir?
Yeah,
Yes,
thank you.
Carry on.
Thank you.
Thank
Have a
you.
nice
Thank you.
next time. Thank you.
See you.
Bye bye. See you.
Bye bye.
See you. Bye bye.
Congratulations.